7 must-check things for performing an accurate hearing test. Firstly, do otoscopy. While you are doing this, you are looking for earwax and collapsing ear canals. In both situations, sounds coming into the ear are attenuated. This will lead to an inaccurate audiogram or artificial conductive hearing loss. Here is a good example. This one is an audiogram of someone with collapsing ear canal tested with headphones. So the ear canal is further squashed by headphone, and this is the same person's audiogram, but tested with insert phones, which support the ear canal to make it stay open. We can see the air conduction thresholds have significantly improved. A collapsing ear canal is found in 36% of adults between 60 to 79 years old, and around 4% of general population. So you really need to look out for it. Second, after checking the ears, position the client in chairs so that they can't see what the audiologist is doing. This is really important because we need to make sure that the patient is not responding to your subtle movements while presenting the tones, but the tones presented to their ear. Although sometimes patients do not mean to cheat or sneakily look at you, the subtle visual cues can still be distracting and hence lead to inaccurate results. Third, once the patient is seated, it's time to let patients know what to expect before they gear up with headphones. Because once they all geared up, they may not be able to hear you easily, not to be mentioned that they could have some sort of hearing loss. Giving instruction before putting the headphones on patient allows them to hear you better, and patients generally feel freer or more likely to ask questions if they need any clarification. Now, headphone placement. We all know a bad headphone placement can again lead to inaccurate result. But what does a good headphone placement look like? Well, firstly, the headphone's diaphragm should be directly over the ear opening, and there should be no hair in between the diaphragm and ear canal, so that the sound can travel straight into the ear canal. And then there should be no gaps between headphone and face, so that sound waves wouldn't leak out. When using insert phones, make sure the tube opening is not blocked and the whole thing is securely in place. Not too deep because it is uncomfortable, or too shallow because it might fall out. And with bone conductor, make sure it is not touching the pinna or top of hair. Last but not the least, double check if the left phone is on the left ear, right phone is on the right ear. I made this mistake several times when I was a student. Okay, next point. During the testing, it is recommended to keep the duration of each tone constant, so patients know what to listen for. However, maybe try not to be too rhythmic, because a rhythmic presentation is likely to make people hallucinate a tone when it's actually not there, which gives false positives that make your life harder. Therefore, try to present the tones at irregular intervals. 6. Once you have completed the audiogram, there are a few things to check. First, look out for standing waves at 6 to 8,000 Hz. In the ear canal, they are created by the interference of two plane waves of the same frequency traveling in opposite directions. In other words, standing waves is when the incoming waves and the reflected outgoing waves cancel each other out. Don't worry about it if it is too confusing. Just remember, standing waves cause the obtained audiogram to be worse than the actual hearing. So if there is an unexpected hearing loss at 6 to 8,000 Hz region, like this, try to adjust the headphone a bit, or switch to insert phones and seek threshold again. Another pitfall is the vibrotactile threshold. This is a problem when people feel the vibration rather than hearing the tone itself. It mainly affects the lower frequencies obtained with bone conductor. So when you present the tones via a bone conductor at 250, 500, and 1000 Hz, always ask the patient whether they have heard the tone or just feel the vibration. Here shows a graph of vibrotactile thresholds, lower limits at problematic frequencies. 7th, the last point is an interesting one. It is to do with validation of the audiogram. In other words, you have to make sure that the patient is not lying to you for whatever reasons, such as compensation claims or some psychological issues. This is one of my favorite parts. I can make another video on this topic. Just comment below if you are interested. It is your like and subscribes that keep me making more and better videos. Thanks for your support and watching. I will see you whenever I see you.